Pediatric tantrums, evidence-informed. Guidance for before, during, and after. Overview. Tantrums are a normative feature of early neurodevelopment. With appropriate adult co-regulation and structured environments, episodes can be reframed from crises into teachable moments that strengthen self-regulation, communication, and attachment security. Operational definition. A tantrum is a time-limited episode of dysregulated affect and behavior such as crying, yelling, flopping, or hitting, occurring when arousal exceeds a child's current self-regulatory capacity, most commonly in the preschool years. Mechanistically, rapid subcortical reactivity outpaces still maturing prefrontal inhibitory control. Adult scaffolding, co-regulation, is therefore central. Common antecedents and early indicators. Antecedents: hunger, fatigue, overstimulation, anxiety, transitions, thwarted autonomy, deviations from routine, skills demands mismatch. Early indicators: frowning, gaze avoidance, low-intensity vocal protest. Refusal of simple requests, motor agitation, increased clinginess. Proactive environmental adjustment at this stage often prevents escalation. During the episode, 3 evidence-informed steps. First, safety and containment. Remove hazards. If needed, relocate to a safe space. Maintain a calm stance, soft voice, and non-threatening body language. Second, adult co-regulation. Breathe slowly. Use brief, concrete statements to anchor the child. I am here. I see you are angry. We will wait together until your body is calmer. Avoid lectures, negotiations, and in-episode incentives. Third, planned ignoring with judicious intervention. With non-dangerous behaviors, use quiet monitoring and planned ignoring. Intervene only when there is risk of harm to self or others or significant property destruction. Notes on specific strategies. Timeout can be helpful for older children when it is brief, calm, consistently applied, and framed as a chance to reset, never humiliating or punitive. Corporal punishment and shouting are not recommended. Both increase arousal and model coercive conflict cycles. Prevention between episodes. Predictable routines, adequate sleep, regular meals, and announced transitions. Daily positive attention. Reserve 10 minutes of device-free, special time, focused on the child's lead. Immediately label and praise desired behaviors. Limited, guided choice. Offer 2 simple options to support autonomy, e.g., blue shirt or green shirt. Early calming skills. Establish a calm corner with sensorimotor tools, e.g., putty, a favorite book, and emotion labeling supports. Coach slow breathing. Cognitive load management. Reduce stimuli before known stress points, supermarket, bedtime, leaving a playground. Anticipatory regulation. Water and a small snack before outings. Brief movement breaks after prolonged sitting. First then contingency. First shoes on, then play. One-step instructions. Deliver a single clear direction, then pause to allow execution. Visual time supports. Use a visual timer or sand timer to make transitions concrete. Functional perspective. Notice the function of behavior, escape, attention, access, sensory, and teacher replacement, asking for a break, requesting help. After the episode, the learning zone. Repair the bond first. Offer proximity or a short hug if the child seeks it. Skip moralizing. Brief, neutral review. What happened? What can we try next time? Keep it concise. Teach one skill only, for example, using a help-seeking word, a stop hand signal, or 5 slow breaths. Intelligent reinforcement. Catch and praise the next approximation, faster calming, appropriate request, or flexible response. Lightweight tracking. A simple antecedent behavior consequence log helps reveal patterns and refine prevention. Practices to avoid. Threats, sarcasm, comparisons, e.g., Your sister is calm, why aren't you? In episode interrogation, e.g., why are you doing this? Over-reliance on screen or gift distraction as a sedative, reserve these tools for deliberate, time-limited regulation plans rather than ad hoc bribery. Physical restraint except when immediate safety requires it, and then only with minimal force and duration. When to seek professional support? Consult a pediatrician or behavioral specialist if any of the following are present. Very intense, prolonged, or highly frequent episodes, for example, more than once daily over an extended period. Self-injury, aggression causing injury, or major property destruction. Loss of previously acquired skills, language, toileting, sleep regulation. Marked developmental delays, severe anxiety, persistently low mood, social withdrawal. Concerns suggestive of autism spectrum disorder. Attention deficit, hyperactivity disorder, language disorder, or trauma exposure. Breath holding spells with recurrent fainting. Ready to use clinical scripts, caregiver language. I can see big feelings. I am staying with you. We can try again when your body feels steadier. First we tidy the blocks, then we choose a story. Say, help please, when you need me. Quick caregiver checklist. Was sleep adequate last night? Has the child had water and a snack before leaving home? Is the next transition announced and supported by a visual timer? Do I have 2 acceptable choices ready to offer? Have I taken a slow breath before responding? Typical course and prognosis. For most children, episode duration falls between 2 and 10 minutes, then gradually resolves. Consistent co-regulation, predictable routines, and skills instruction are associated with fewer episodes and milder intensity over time. Professional caveat. This guidance is educational and does not replace individual clinical assessment. When in doubt about safety, development, or differential diagnosis, seek timely evaluation.